Hello and welcome everyone. My name is Matt Shepard and I'll be your moderator for today's Team Gleason Center for Medicare Advocacy webinar, Case Studies, Pathways to Maximize Medicare Home Care Coverage and Access to Care for People Living with ALS. This webinar is brought to you as part of the joint Team Gleason Center for Medicare Advocacy, Medicare and Home Health Initiative to help people living with ALS understand Medicare, including the home health benefit, and to maximize access to coverage and care. A little bit about our organizations. The Center for Medicare Advocacy, as some of our audience know by now, is a nonpartisan, nonprofit organization which, since its founding in 1986, has worked to obtain fair access to Medicare and quality health care for older people and people with disabilities through education, training, analytical research, advocacy, and legal assistance. The center is staffed by attorneys, advocates, nurses, and technical experts, all working for systemic change based on our daily experiences with the problems of real Medicare beneficiaries. Team Gleason's mission is to help provide individuals with neuromuscular diseases or injuries with leading-edge technology, equipment, and services, to create a global conversation about ALS to ultimately find solutions and an end to the disease, and to raise public awareness toward ALS by providing and documenting extraordinary life adventures for individuals with muscular diseases or injuries. The Medicare and Home Health Initiative includes our two prior webinars, giving an overview of Medicare for people living with ALS and home health care for people living with ALS, and today's webinar. Thanks, by the way, to all of you who attended last week's and the prior webinar, and apologies if all this background info sounds familiar. But continuing that background, the Medicare and Home Health Initiative also includes a dedicated email portal for those living with ALS to ask questions and share their home health access stories. Please do share stories. You can share those at homehealth@medicareadvocacy.org. In addition, our center attorneys will host several virtual town hall calls. These will be every second Wednesday of June, July, and August for people living with ALS. We will discuss answers to your questions that you've submitted. We'll discuss some of those stories, and we'll take more live questions. And you can actually register for those town halls right now, just below the Gleason webinars on our webinar page, www.medicareadvocacy.org/webinars. Again, we can't thank Team Gleason enough for their support of this important initiative. Today's case studies webinar will be presented by Center Executive Director Judith Stein and Associate Director Kathleen Holt. Before I let them start, though, more housekeeping that's going to sound familiar to some of you. If you can hear me, you've used the information in the email you received after registration to successfully log into the webinar, and you've either dialed in by phone or you've got good quality working speakers on your computer, either of which is great. If you've used that telephone call in, we will also be able to hear you when we open up for questions. Otherwise, please be absolutely certain your computer has a good quality microphone. And if you aren't certain, it's never too late to dial in using the instructions provided on your confirmation email or under the audio tab on the control panel that's at the right of your screen. If, as happens very rarely, you've dialed into the audio without logging into the online portion, you can hear us, but you won't actually see that control panel or the presentation. You do need to log in or you won't be able to interact with us today. So let's discuss the control panel I've mentioned a couple times. There are some key features on that panel for our purposes today. Please note the buttons on the tab at the left side of the panel. There's a little orange arrow. That lets you hide the panel so it's not in your way. There's a little square. That'll let you watch the presentation in full screen view. And then there's a little picture of a hand. This one's the important one. This is used to indicate you have a question. For the bulk of the presentation, we're going to keep our attendees muted, but when we open it up for questions at the end, you can use that icon to indicate you wish to speak, and I'll unmute you. And don't worry if we don't get to your questions live, or you're shy, decide you don't want to ask it aloud, or, as happens most often, somehow we just can't hear you, you will have a perfect opportunity to ask questions at our first town hall call on June 13th at 3 p.m. Eastern. So please do register after this webinar. Also note that this presentation today will be recorded for future viewing, so if you don't want to be heard or have your inquiry read live, please do follow up with us after the fact. And finally, while everyone should have received a copy of today's slides at the email address used to register, if for some reason those didn't make it, you could download them right now in the handouts section of the control panel. Thank you all once again for attending. And now I'll hand things over to Executive Director Judith Stein. Judy?
And welcome to the recap of Medicare home health coverage and case study webinar. We're so pleased to be with you this afternoon. The agenda for today is to give a basic summary of the Medicare home health coverage so we make sure we're all on the same page, and then to go over two case studies which will bring out and highlight some of the issues that we know a lot of people are facing when they try to access the Medicare home health coverage that they're qualified for under the law. So we will have two case studies, and then we'll discuss some more practical issues, appeals, and resources briefly. And finally, we will have time, as Matt said, to answer questions and to have a bit of a discussion for the last half hour of this presentation. With regard to recapping the Medicare home health coverage criteria and the coverage that what services can be provided and covered, I'm going to assume that many of you have heard our other webinars and try and highlight some of the concerns that we think that many people living with the ALS and other long-term and neuromuscular conditions face when they try to get Medicare coverage for home health care. So a basic summary: to qualify for coverage, you need a doctor's order, or what is known in the law as a plan of care. Patient needs to be homebound, needs a skilled service, which is either skilled nursing on an intermittent basis or physical therapy or speech language pathology to qualify you for coverage. If you do qualify, then Medicare will cover nursing, physical therapy, speech language pathology, as well as occupational therapy, home health aides, medical social services, and some supplies. We want you to know that you can what's known as oftentimes as split bill, and that means that if you have another payment source or if you're paying for some services out of pocket, you can still get Medicare coverage under the law for some of the services that Medicare covers. Also, we want to make sure, and I'll keep reiterating this, that you know that restoration potential should never be the deciding factor in concluding whether Medicare coverage is available. And also that the home health benefit has no duration of time limit for those who meet the basic qualifying criteria that I just went over. So let's look at those criteria again. You do need to have a doctor's certified plan of care or order for the services that you're to get, and those services must be provided by a Medicare certified home health agency in order to get Medicare to cover. The doctor must certify that a face-to-face meeting has occurred. That means that he or she or another qualified health professional like an advanced practice nurse has met with the patient and gone over the facts of the case and ensured that the person does meet the homebound criteria and does need skilled nursing therapy and home health aid services. The other nurse, the nurse or other qualified provider like a physician's assistant can have that encounter, but the doctor must sign off on it. Now, you also do need to be homebound, which means confined to home, but not bedbound. And we'll go over that in a little bit more detail because that is important for people living with ALS and others for sure. And the person needs to be in need of reasonable and necessary skilled services, as I said earlier, which means at least one of the qualifying skilled services: intermittent nursing, physical therapy, or speech language pathology. And I want to point out, as we have on previous webinars, that we have the references, the legal citations for you to use to prove the points that we're making. So we're not just making this up. You can find what I'm telling you here in what's known as the Code of Federal Regulations. That's what CFSR stands for. And that little squiggle sign means section. So it's at section 409 of the volume 42 of the Code of Federal Regulations. And the EDSEC means and the following materials. So that's where you'll find the basic federal regulations regarding home health care. Now, a little bit more about each of these qualifying requirements. The doctor, as I say, must have certified that the care is necessary, and that must be done in writing. And it must be reviewed every 60 days or more often if necessary. And one of the practical tips I want to say is that if the goals change during the 60-day period, so for example, if it starts out that the doctor thinks that the therapy may be able to help a person ambulate without assistance because they can strengthen some of the weakened limb, they would put that into the original goals. But if that changes over the course of the 60 days, the doctor and therapist should be noting that in their orders and changing the goals so there isn't a denial based on the original goals. The doctor has to sign off on that face-to-face meeting I talked about, and that means that a qualified health professional or the doctor has met in person with the patient. And here again are citations to the Code of Federal Regulations that speak about the points I've just made. Now, here's a very important piece. A person, in order to get home care, a person must be what's known under the law as confined to home, and that is often referred to as homebound in everyday parlance. Now, the intention here is to make sure that Medicare dollars are spent for getting care to people only when people can't legitimately get to that care themselves. So the individual has to require, under the law, assistance of another person or a supportive device like a wheelchair or a walker or even a cane to leave home, or it has to be contraindicated for him or her to leave home due to his or her medical, cognitive, or psychological condition. So that means that somebody might have the wherewithal physically to leave, but really shouldn't be doing so, or can't do so because of their have a psychological impairment. And that there is a normal inability to leave home. You know, fortunately, I can leave home by myself most of the time. I do not have a normal inability to leave home. That does need to be the case, even if you meet the prior qualifying criteria. And it needs to require a considerable and taxing effort to leave home. And here we have the Medicare Benefit Policy Manual, Chapter 7, at Section 30.1.1. This is the Benefit Policy Manual is where the home health agencies usually look to get their direction for when Medicare will cover. I just want to correct something I just said, and that is that if you need the assistance of a person or a supportive device, then you need to meet one of the following criteria where you see the and. So it either has to also be that you need a device, or that it's contraindicated for you to leave home and there's an inability to leave home normally. Now, services that trigger or qualify an individual for care, that is to begin coverage, are intermittent skilled nursing, as we said, or physical therapy or speech language pathology. Intermittent skilled nursing is a nursing service that occurs at least once every 60 days and will recur, or less frequently than daily, or daily only on when it's expected to end after 21 days. And I'll talk about that in a minute as well. And then there's that can trigger begin coverage. You can also begin coverage as a result of needing and receiving physical therapy or speech language pathology. So if you somehow were getting nursing services that don't meet the intermittent definition, but you were also getting physical therapy or speech language pathology, you could qualify for Medicare coverage as a result of those therapies. And if you do qualify, and the nursing and PT and speech language pathology that were being provided are no longer being provided, but occupational therapy is continuing, then that will be sufficient to cover continue Medicare coverage. The occupational therapy can continue Medicare coverage, can be skilled care to continue coverage, but not to begin it. And there you have the Code of Federal Regulation, again, for home health care. Now, what does skilled mean? Skilled means a qualified professional, so a nurse or a therapist is needed for the care to be safe and effective. And it needs to be that the nurse can be needed or the therapist can be needed to provide or to supervise that care. So one of the things we want to make sure is that that it's all well and good for lay people, family members to be taught certain services and to help out if they're willing and able. But it is not true that a non-skilled person can be expected to do what a qualified nurse or therapist can do in order to make the care safe and effective. And that's what we want to make sure people get. That is safe and effective care as is really needed, not what the home health agency may think the lay caregivers and family members can do. Skilled nursing and therapy are defined at the Code of Federal Regulations, Section 409.33, which includes a list of services that will equal, under the law, will be considered skilled nursing and therapy. You can find them here at 42 CFR 409.32. Note also that so long as those skilled services are required and provided, Medicare coverage should be available under the law. And we know that that's sometimes honored in the breach, but that is the law. In fact, that language, so long as, is the language from both the Medicare regulations as well as from the manual. And here you have the policy manual citation, Chapter 7, Section 40.1.1. And again, the benefit policy manual is what is often used by the home health agencies. And so you want to be very aware of what's in that manual. So here are some very important key points. An individualized assessment is required by the law regarding the eligibility for coverage of each Medicare beneficiary. You shouldn't hear things like, oh, people with that condition, that diagnosis, don't get Medicare coverage, or Medicare only covers 2 weeks for home health aides ever, or any other rule of thumb, we call it, to define what coverage is available under the law for each individual patient. Instead, it is required that the individual is looked at and that a good faith assessment is made about what that individual needs based on whether the skilled care is needed to improve or to maintain the person's condition or slow decline. The restoration potential of an individual and the individual's condition should never be the deciding factor. The question is whether that skilled care is needed. And that's so important for people living with ALS, because we know regrettably that very often improvement is not possible, but it sure is true that getting the necessary skilled nursing and skilled therapy can very much help with preserving current capabilities or preventing or slowing deterioration. And as you see here in point 4, that should be equally covered under the law. If skilled therapy is needed to preserve current capabilities or slow deterioration, that's coverable under the law. And as I said earlier, home care can continue so long as these qualifying criteria are met. Make sure a good faith decision is made about that. Home health agencies, by the way, must submit claims to Medicare if a beneficiary requests so. So if the agency tells you, well, Medicare is not going to cover that, and you can't talk them out of that based on what we're teaching you here, you should nonetheless try and, if you can, keep the services in place. And while you're doing that, excuse me, insist that they submit the claim to Medicare so that you can get a determination from Medicare with regard to whether that coverage can be granted. And if not, you can appeal it. So with that, let me proceed to hand this over to Kathy, and she'll go over our first case study. Kathy? Oh, wait. I want to talk first about dependent services,
Okay,
don't
go
I?
first.
There I do.
Okay.
Okay.
I'll wait.
Next, we'll do case study, but I want to talk about this very important point next, which is the fact that if those skilled services I just described are in place, are provided, then you can get Medicare coverage. And this is so important, of course. If that's the case, then Medicare will also cover the other skilled services I described, which is further nursing, physical therapy, occupational therapy, and speech language pathology, and perhaps most importantly, these dependent services. And by dependent, they mean they're dependent on getting the skilled service. And if you do have the skilled service, then Medicare will also cover home health aides, which are so important. And they will cover, Medicare will cover part-time or intermittent home health aides to provide personal care. And also medical social services such as a medical social worker or psychological nursing services, and certain medical supplies that are related to the person's condition. Now, home health aides can be provided combined with the skilled nursing up to 28 hours per week, any number of days per week, as long as they're provided less than 8 hours a day. This is under the law. And subject to review on a case-by-case basis, they may be available and covered up to 35 hours per week combined with the nursing. So you can see that that would be like if a nurse came in a few times a week, and then the home health aide was in the morning for an hour or two, and then again and again in the afternoon. Under the law, that would be coverable. And here's a reference for that point to the United States Code. That's what USC stands for. And that's the law, the actual Medicare Act, the statute, at section 1395 XM7B. That's where you can find the law with regard to home health aides. Now, those home health aides can provide personal hands-on care and be covered by Medicare. Homemaker services alone are not covered. That means like cleaning up about the house, putting things into the fridge. If those are incident to the personal hands-on care, then that's okay, and Medicare won't diminish its payment. But it won't cover the homemaker services alone. However, Medicare does specifically establish home health aides as a covered service, so don't accept being told that that's a custodial care and that Medicare only covers skilled care, because home health aides are an exception to that point. And another thing we want to make clear that you know that the law provides for hands-on personal care, which includes feeding, dressing, helping with elimination and bathrooming and catheter care, not just bathing. Bathing is one, but not only one, of the personal hands-on care that Medicare should be covering. And I want to call your attention to 42 CFR 409.45, it's section B1, I believe, where you will find that definition of home health aides. And we know that people are hearing that they can get a bath, and that is one, but not the only thing that home health aides should be providing. Another note, sometimes you may hear that that amount of nursing doesn't qualify you for that amount of home health aid services. There's no such rule in Medicare law. So if you hear that, ask the home health agency to tell you where they get that from, because it's not true. Now, another thing we know that people often have to deal with is being told that the home health aides or nurse or therapist won't be covered because they have a caregiver at home, or the home health agency discerns that the family should be able to do the particular care. Now, first of all, question that, because after all these years of the work I've been doing and we've been doing here at the center, We know what a therapist, skilled therapist, and a nurse can do, and that is, they're professionals. They've gone to school. They're certified. They're professionals, and they're qualified to do therapy and nursing in a way that the lay caregiver is not, that a family member is not. So first of all, it's probably not going to be as safe and effective for a family member to do it. But even if somehow it is, if the family member is, there is no presumption. In fact, it's the opposite. There should be no regard to whether there is someone available to furnish the services when making a determination whether Medicare should cover the nursing, therapy, or home health aides. Indeed, the Medicare Benefit Policy Manual, that Chapter 7, the home health section, at Section 20.2, says that ordinarily it's to be presumed that there's no able or willing person at home to provide the services that are being sought from the home health agency. So that should not be a bar to getting Medicare coverage. Now, I also want to reiterate that decision as to whether Medicare coverage is available should be made with no rule of thumb. Do not accept hearing that, oh, people with that condition or people who can still walk that many feet or any other rule of thumb is acceptable. An individual determination is required. And as you see here, here's the quote from the federal regulation. Based on solely on the individual beneficiary's unique condition and needs. And look at this quote, how important this is. Without regard to whether the illness or injury is acute, chronic, terminal, or expected to last a long time. And this too comes from the federal regulations, which is law. And I hope that you'll keep these slides and use this information and maybe even show this to someone at the agency if you're told otherwise. If the home health agency says that Medicare won't cover, tell the agency to submit what is known as a demand bill. And that means you demand that the bill be submitted to Medicare for all the coverable services included on the doctor's plan of care. So that would be up to 35 hours a week of home health aides and nursing combined, and speech, language pathology, physical therapy, or occupational therapy, and any other dependent services that the doctor had ordered. Very often that, of course, means the home health aides. The agency must submit that bill to Medicare at your request and tell them to submit it using a code 20. That means that there will be a medical review done. That's a practical tip, because we don't want the deciding entity to make just a perfunctory determination and just automatically deny. Now, it is true that while this occurs, the agency can require payment for ongoing services. So we don't pretend that this is easy, but they do have to submit a demand bill if the services are provided and are coverable as we just suggested. Now I will send it over to you, Kathy, for the first case study.
Thanks, Judy. Great. And we felt it was really important to go through the details again. I know it was hopefully a refresher for folks, as well as for those who might be jumping onto the webinar for the first time. But the case studies that Judy and I are going to look at hopefully will bring all this information that you've learned about the nuts and the bolts of coverage together. And there will be quite a bit of detail in the illustration. And it's not meant for you to, again, remember everything as much as to know as a resource, put it all together, understand it in a case study type of a vision, and then be able to look back on these materials. Judy spent a lot of time talking about the citations, the places in the law, in the manual, in the regulations, where all of this information is contained. And that's just, again, critical resource material. So now we're going to meet Mr. Jones in case study 1. Mr. Jones has ALS. He has traditional Medicare, primary with secondary insurance through his wife, Mrs. Jones. When Mrs. Jones is not working, she is Mr. Jones's caregiver. A friend visits with Mr. Jones a few hours daily to keep him company and essentially read the newspaper to him and just hang out. Mr. Jones uses a cane and his balance is worsening, and he now needs assistance 24 hours a day with everything. It takes hours and assistance for Mr. Jones to groom and dress. His stamina is quickly depleted. He does leave home for medical appointments, church services, weekly support group meetings, grocery and post office errand runs, occasional special celebrations, birthday dinners out, for instance, graduations, and daily short outings in the neighborhood park. He also has a vacation home in another state that he often visits with his family. So now the questions are, does Mr. Jones qualify for Medicare home health, and what are the services that he needs? So the first thing Mr. Jones will do is contact his doctor for an appointment to discuss home health care. They meet to discuss his needs and to plan for necessary services at home. Mr. Jones and his doctor discuss his needs. He needs physical therapy to help slow progression and maintain his current functioning as much as possible, and to receive respiratory therapy treatments. He needs speech-language pathology for an SGD, speech generating device assessment and training. He needs daily skilled nursing for 17 to 14 days to observe. I'm sorry, did I say 17?
Yeah.
Thank you. That's why I have Judy with me.
That's why I have Kathy too.
7 to 14 days to observe the new gastronomy site and train on tube feedings. He also needs intermittent skilled nursing to routinely assess his overall treatment plan relative to his changing condition. He needs medical social services, both for himself and for Mrs. Jones, to help them both adjust to their changing lives. And he needs a home health aide for hands-on personal care. And this is where I have to say we did change. So if you have the original slides, my math isn't as good as my law. And so it originally said 10 hours a day. So actually, Mr. Jones needs a home health aide 12 hours a day. So if you have the slides printed out, change that 10 to a 12. So again, for hands-on personal care, 12 hours a day, 5 days a week, to make sure that he is safe. And also for 8 hours at night, 3 days a week, to help reposition and monitor his needs. So let's take a look at the checklist that Mr. Jones needs to qualify for coverage. Mr. Jones is under the care of a physician. He is homebound. He needs intermittent or part-time services from skilled professionals and aides. His reasonable and necessary, his needs are reasonable and necessary for the home health services. And there is no willing and able caregiver available during some periods of time. So now we'll look at each of these checklist items individually. Mr. Jones is under the care of a physician. The physician duties in this process include the following: to provide certification with a face-to-face encounter to certify needed care and homebound status. The doctor should also prepare a plan of care, and the plan of care includes the following: all of his pertinent diagnoses, ALS and any other diagnoses that he's being treated for under the home health plan of care, identification of the course of treatment, an order for home health care services, and justification of home health aides and skilled nursing hours beyond the 28 hours a week. And then to recertify after the first 60 days, the doctor would be required to review, sign, and date another plan of care at least once every 60 days. We know that Mr. Jones meets the qualifications for the homebound status. Because of his ALS, Mr. Jones is unable to ambulate safely without the use of an assistive device, his cane, or with another person. He is normally unable to leave his home because of the considerable and taxing preparation involved to groom and dress, and because of his diminished stamina. And when he does leave home, it is either for brief periods or very infrequently. We had I'm just going to pause for a second because we had a question in our list of questions that we got whether or not Stephen Hawking would have been considered to be homebound. And through our analysis, we essentially felt that he missed that last criteria of not leaving home infrequently or for brief periods. So he would not have been considered homebound by Medicare given that circumstance. So remember when we met Mr. Jones, we learned that he had a vacation home. So Mr. Jones can alternate between his main home and his vacation home and still be considered homebound. And the rule says, and I'm quoting, the fact that the patient resides in more than one home and as a result must transit from one to the other is not in and of itself an indication that the patient is not homebound. The requirements of homebound must be met at each location, and that location could also be a mobile home or the home of a caretaker relative. So there's some flexibility in that the home doesn't necessarily have to be just the primary home. Now we know that Mr. Jones is under the care of a physician and he's homebound. So let's look at what the certification content requirements are. A certification is considered to be any time that a start of care, the OASIS assessment, that's the assessment that's performed by the home health agency when they come in to look at what's necessary in order to complete or fulfill the order of the doctor. And that has to be completed and initiated through the home health agency. But the physician must certify that services are needed because Mr. Jones is confined to his home, that Mr. Jones needs intermittent skilled nursing, physical therapy, or speech-language pathology. Again, my typo error there. The word "and" is not correct. It should be "or." So skilled nursing, physical therapy, or speech-language pathology. And again, note that only the skilled services must be certified. The dependent services, while they're ordered, are not required to be certified. A plan of care has been established and is reviewed periodically. Services will be furnished under the care of a physician, and Mr. Jones' face-to-face encounter must be documented. And as Judy mentioned, the face-to-face encounter can be performed by either a physician or a non-physician practitioner. And those include nurse practitioners, clinical nurse specialist, certified nurse midwife, or physician assistants under the supervision of a certifying physician. The encounter should be related to the primary reason Mr. Jones requires home health, his ALS diagnosis in this case, and no more than 90 days before the start of home care or within 30 days after the start of care, the face-to-face encounter must take place. There must be a doctor to certify the plan of care. And the plan of care, again, has to contain all the pertinent diagnoses, and the orders on the plan of care must indicate the nature of the service, whether it's PT, OT, for example, the type of the professional who will provide the service, and the frequency of the service, how often the individual needs to have the service performed. The plan of care must be reviewed and be signed by the physician who establishes the plan of care in consultation with the home health agency. And again, note that the family and the patient are an integral part of the plan of care, particularly under the new conditions of participation in Medicare. So the patient and the family should be working with the home health agency and the physician to make sure that everyone is in agreement and on board with the amount of care that will be provided. And that will happen at least every 60 days. Each review must contain the signature of the physician and the date of the review. And the plan of care must reflect the physician-ordered services that the home health agency provides, either directly or under arrangement. And I'll talk about under arrangement in a minute. The home health agency is responsible for the payment under arrangement. So the way Medicare works is the home health agency will determine the bundle of services that's necessary. A payment for that bundle will be assigned to the home health agency. And if the bundle contains services that are performed outside the home, for instance, in a clinic, that the home health agency will take some money from their bundle to pay for the services that are performed outside the home. So again, the plan of care has to contain the pertinent diagnoses. And in Mr. Jones's case, and in all cases, it's not just this. The mental status is included in the pertinent diagnosis, the types of services required, supplies, equipment, frequency of the visits to be made, prognosis, rehabilitation potential, functional limitations, activities permitted. You see, I mean, I could go on, but I think this is a really good slide for you to have as a reference to know what the requirements of what goes into a plan of care. Again, these are not complicated issues so much as it's, again, a checklist of all of these requirements that make up the plan of care. Now, there is a specific plan of care that is to be drawn up if there is a therapist involved. And the course of Mr. Jones's therapy treatment must be established by his physician with the consultation of the therapist. And that plan of care must include measurable therapy goals which pertain directly to Mr. Jones's illness. So measurable goals include maintaining functioning and slowing progression of a loss of function. The expected duration of the therapy services must be included, and a description of the course of treatment consistent with the qualified therapist's assessment of Mr. Jones's function. So let's look a little, this is a very complicated slide, and I don't mean for it to be, again, it's a reference, but this is what a physician order for skilled care might look like. So the nomenclature, if you will, states at the first bullet is skilled nursing visits 7 times a week for 7 to 14 days. And remember, this was an order that was to check the placement, the new gastrostomy site, and to make sure that it was healing properly and to help train the family members on tube feedings. So the doctors ensure how long that's going to take. It could take up to 7 days. It could take up to 14 days. So when the doctor writes an order with a range of days in it, what that means is that there's no need to get approval as long as it's no more than 14 days. So it will be, the range is the higher end of the range is essentially what is considered to be reasonable and necessary for the patient. If the doctor had just said for 7 days and it needed to be longer, then the order would have to be revised if it goes beyond the number of days in the order. So in this case, we have the skilled nursing 7 times a week. So that's the daily skilled nursing that can happen for up to 21 days. So in this case, it's 7 to 14 days. And then 1 time a week for 8 weeks. And remember that that check-in is for assessment and management of Mr. Jones's course of functioning and his experience with ALS. So that there are 2 separate orders, if you will. But in this case, we have the order of 7 times a week for 7 to 14 days, and then 1 time a week for 8 weeks. So that it's assumed that the assessment piece of this, the 1 time a week, will be ongoing. And the 8 weeks is representative of that 60-day period in which the doctor is certifying care. Okay, so then we have physical therapy visits, and it's determined that through talking to the physical therapist and the doctor and understanding the needs that Mr. Jones has, that he needs to have physical therapy 2 times a week for 8 weeks. And again, we have to give a reason. Why does he need them? Well, he needs them for skilled range of motion extremity exercises to minimize his pain, to help him keep as much flexibility as possible. Whatever the order is, again, maintaining or slowing progression of his loss of function, lung capacity. There are different reasons why people need, and we're not the clinician, so we're not going to give you anything more probably than some examples that will help the clinicians to determine the appropriate documentation. But these are the reasons that are necessary, and again, in order to make that physical therapy happen. Maybe and then in the order continues, he needs speech language pathology, and the doctor and the speech language pathologist estimate that it will take 10 visits over 8 weeks, and those are through arrangements to be made with the home health agency to have the speech language pathologist at a clinic evaluate and train for appropriate SGD selection and use. So the physician orders for dependent services. Again, the doctor orders medical social services 1 time a week for 8 weeks. And again, this is to help to counsel Mr. Jones and also assist to understand what resources are available in the community. That's a lot of reason why someone would use a medical social service person. In addition, there's an order for medical social services once a week for 4 weeks. And that would be so that Mr. and Mrs. Jones together can help develop communication and coping skills over his illness. A lot of people don't realize that Medicare will cover, for instance, a family member to have counseling or a spouse to have counseling by a medical social service person, as long as that the services are to also be helpful to the Medicare beneficiary themselves. And in this case, we see that Mr. Jones and Mrs. Jones need to figure out how to talk better about what's happening with Mr. Jones's illness, and so that's why Medicare would pay for services that will also help Mrs. Jones. The home health aide 5 times a week. So we have this split up because essentially what's happening here is during the day there are hours needed, and then in the evening there are different hours needed. So during the day, 5 times a week, there are visits by the home health aide who is going to help Mr. Jones with toileting, dressing, bathing, feeding, preparing him some light meals, laundering of his sheets and his bedding and his pajamas and his clothes, and other personal care services. These are, and also monitoring his condition as needed. And so, for instance, if the home health aide sees that Mr. Jones is in distress, that person would be there to contact someone to get some extra help. But essentially, we're seeing that this is the order for the home health aide. And I'll give you a little more information in this particular case study about why, what hours are being used at what point for a home health aide. And remembering that we've determined through the beginning of the case study that Mr. Jones does need assistance 24 hours a day. And then another order for a home health aide 3 nights a week. And that would be to assist Mr. Jones with positioning during the night and any other needs that he might have if he's unable to sleep or upon awakening. So that's essentially what the physician orders look like. So the services provided must be medically reasonable and necessary. And again, documentation of this is critical. So objective clinical evidence regarding Mr. Jones' need for skilled care must be documented. We often say, because we see this happen time and time again, if it's not documented, it didn't happen. Of course it happens, but if it's not documented, you can't show that it happened. So it's important to document. The need for skilled care is based on information that's reflected in the home health plan of care, the OASIS, which is the home health assessment needs tool, or a medical record of Mr. Jones. So again, documentation backup. This is where Medicare determines whether the care is reasonable and necessary. Also, when a family member or other person is or willing to be providing services that adequately meet Mr. Jones's need, it would not be, according to the policy manual, reasonable and necessary for home health aide personnel to furnish such services. But as Judy mentioned, it's presumed there is no able and willing caregiver unless Mr. and Mrs. Jones indicate otherwise, or the home health aide agency has firsthand knowledge to the contrary. So if for some reason the home health agency found out that Mr. Jones's neighbor was providing him with the equivalent of home health aide, then the home health agency might say, well, he's already getting it from another source. But we know in this case that Mr. Jones's neighbor has definitively said, I just want to read in the newspaper and I want to visit with him. I don't want to be responsible for doing any of his caregiving. So again, there is no willing and able caregiver unless someone states it. So and again, in this case, Mrs. Jones is unable to care for Mr. Jones's skilled needs, such as evaluating his SGD, performing his physical therapy exercises, and assessing his overall treatment plan. Those are skilled needs, and that's a given. But then Mrs. Jones has also indicated that she is willing and able to care for her husband's personal care needs, except for the following times. And I have to say that Mrs. Jones has been very adamant and very clear about when she's available and when she's not available. So she says, during my work hours and my commute, which is a total of 45 hours a week, the hours that I do errands, or Mrs. Jones does her errands, 15 hours a week. So there we've got a total of 60 hours that she's not available. And 3 nights a week for 8 hours when Mr. Jones needs care if he awakens. And essentially what Mrs. Jones is saying is, I'm okay every other night sitting up with my husband if I need to, but I really do need to have my own sleep time and be able to recover. So no, I am not available 3 nights a week for 8 hours a week when Mr. Jones needs care. So we're looking at a total of 60 hours during the week and another 24 hours, 3 nights a week, 8 hours a night. So that's 84 hours total when Mrs. Jones has made it clear that there needs to be something, some other availability of aides. And then Mr. Jones, as we mentioned, is unwilling to care for his personal needs. Remember, this is a case study. So for those of you who are saying, this is not going to happen, hang on a second. Let me get through the case study, and then we'll talk about what the reality of everything is at the backside, but we'll get there. So I also want to share with you this very important example. I can't tell you how many times I've referred to this. This is to illustrate Medicare home health aide coverage. This is on page 82 of the Medicare Benefit Policy Manual, Chapter 7. This is from Medicare. Medicare has put this out. I check all the time to make sure it's still there. But the example is that a patient needs skilled nursing care monthly for catheter change. So that's why they get a skilled care, right? That opens the door to them being able to get home health care. And the agency also renders needed daily home health aid services 24 hours a day that will be needed for a long and indefinite period of time. The home health agency bills Medicare for the skilled nursing and home health aid services, which were provided before the 35th hour of service each week. So remember, you can get up to 35 hours of combined skilled nursing and home health aid, and bills the beneficiary or another party, such as another insurance, for the remainder of the care. If the Medicare contractor determines that the 35 hours of care are reasonable and necessary, Medicare would cover the 35 hours of skilled nursing and home health aid visits. This is an example directly from the Medicare Benefit Policy Manual. Okay, so again, how do we justify that home health aid and nursing hours are required beyond the 28 hours? The law says that if someone needs Medicare to cover home health aides for more than 28 hours, the physician must justify the needs. So Mr. Jones has no willing and able caregiver 60 hours each week during the day. When Mrs. Jones is working, she's commuting, she's doing errands, and has no willing and able caregiver 24 hours a week during the nighttime. Mrs. Jones' doctor has recommended she get 3 uninterrupted nights rest a week to avoid burnout. Yet Mr. Jones requires constant assistance 24 hours a day, 7 days a week for his own safety. Mr. Jones is not able to perform any self-care tasks without the potential to harm himself. So again, note, Medicare may cover up to a combined 35 hours a week of skilled nursing and aid services. But Mr. Jones' secondary insurance may pay for the remaining hours of care each week. So Medicare allows this type of split billing, as I just mentioned in the previous example from the previous slide. So this would be what would happen in Mr. Jones's case for Medicare coverage of nurse and home health aides. So the first 2 weeks, he would get, again, the total of 35 hours, because as we mentioned from the last slide, that was the documentation that's necessary to justify having up to 35 hours of total care between a nurse and a home health aide. But remember, in our case study with Mr. Jones, he is, the first 2 weeks of his care, he's going to get 7 hours of daily nursing care for his gastrostomy, and then 1 hour for his overall care, the assessment and management. So in the first 2 weeks, he's getting 8 hours of skilled nursing care. So that leaves 27 aid hours covered by Medicare. And then on week 3 and after, he's only getting 1 hour of skilled nursing for the overall care, assessment, and management. So then that leaves him with 34 aid hours that are coverable by Medicare. And again, so the next step would be, how do you find a Medicare certified home health agency? We have heard actually since, and we hear on occasion, but we've heard since we've started up the Gleason webinars that there are a lot of good guy, not a lot, but there are good guy home health agencies out there that are really trying to do the right thing and really trying to provide up to what Medicare compensates for. So again, this is the Medicare Home Health Compare, and Mr. Jones would look it up by his zip code to see how many Medicare certified home health agencies serve his area, and he can contact to see if they will come and do an assessment of his needs. There are clinician referrals, ALS organizational referrals, hopefully through support groups that will help you to narrow down the choices even more of the agencies that are out there that can really meet your needs. Oops, I'm sorry. What did I do? Pressing the wrong button. So sorry. So again, just to mention the services that are provided by arrangement with certified home health agencies. So once Mr. Jones chooses his home health agency, that home health agency, as I mentioned, must provide all the covered home health services, either directly or by arrangement. And then they must bill for those covered home health services as a bundle through Medicare. Home health agencies provide services under arrangement at hospitals, skilled nursing facilities, or rehabilitation centers when they, for instance, involve equipment that's too cumbersome to bring to the home, or they could be furnished while the patient is at the facility to receive other services. And they are, again, included in the home health base payment rates. And we have heard of clinics where speech language pathologists have, if you will, group trainings, and those are sometimes paid through by arrangement with a home health agency. So I do want to caution everyone that a home health agency would not be responsible for payment in the situation in which they have no prior knowledge that they are providing something under arrangement. So if a patient just assumed that they could get care and it wasn't through the knowledge of a home health agency, that would be outside the plan of care and outside what the home health agency that you have the bundled arrangement with would cover. So just be careful of that. And then there needs to be a recertification every 60 days. So within the last 5 days of the previous episode, so essentially day 56 through day 60 into an episode, it's required that a recertification assessment be performed in order to continue the services. We've had people say, well, whose responsibility is that? Is it mine to make sure the home health agency does, or should the home health agency take care of it? You know, I always say communication is going to make you happier in the long run. So make sure that you have a clear understanding that the home health agency will initiate the recertification and make it happen, or if they want you to somehow be involved in doing that. But ensure that the physician is aware of the requirement timeframe. And just so you know, the face-to-face encounter is not required for recertification. It is required at the initial certification. So as far as payment for non-Medicare covered services, Mr. Jones, as we know from this example, has secondary health insurance through his wife. And because her business has less than 100 employees, Medicare is primary. Otherwise, if she was with a larger employee, as we mentioned in the first webinar, Medicare might be secondary. But in this case, we know that Medicare is primary, and Medicare will cover up to 35 hours a week of the combined skilled nursing and home health aid services. And again, I'm sorry, my math is way out of whack here, because that number should be 50. And one would say, okay, if you add 35 and 50 instead of 25, it's 85. But again, remember that there was that 1 hour of nurse. So it's a little complicated. But in any event, Mr. Jones would bill the additional 25 hours to his secondary health insurance because he's fortunate enough to have that. And that's where he's at. So that's the end of case study 1, and I'm going to pass it back to Judy. And I'm really sorry, we're kind of late on time.
No problem. We'll just go ahead with Mrs. Drew. And this is our, this case study is going to show us about folks who need coverage and might be having challenges because they're being told that they have a diagnosis that means they won't get better and regain all their prior capabilities. So Mrs. Drew was diagnosed with ALS 2 years ago. She's a widow and she lives alone. Her 2 adult daughters and their families live about an hour away. She, unlike Mr. Jones, is enrolled in Medicare Advantage plan. You'll recall that he was a participant in the traditional Medicare plan, but Mrs. Drew is in a private Medicare Advantage plan. And she's been receiving home health coverage through the MA plan. She gets physical therapy 1 time a week, occupational therapy 1 time a week, nursing 2 times a week, and home health aides 2 times a day, Monday through Friday. This is probably more like what a home health agency would expect to see in an order. The care order, the plan of care that Mr. Jones had was certainly more intense. The home health agency, however, nonetheless, told Mrs. Drew that her home health coverage was ending because she was not improving, and the agency didn't believe that, therefore, that Medicare would pay for her care. Now, here are some questions to ask. Can the home health agency be persuaded to continue care as ordered by the physician? That is, are we going to be able to keep this care in place so that we can do something about the Medicare coverage? Did Mrs. Drew get a written denial notice? And if so, always ask, and if so, get a copy. Did the doctor who ordered the home health care discharge Mrs. Drew from the care? It is not infrequent that we learn that the doctor had no idea that the home health agency said the care was ending, and the doctor should know, and indeed the doctor has to agree with and discharge the individual from care. It's not up to the agency to do this under the conditions of participation of being part of the Medicare program. Also, we want to know if the doctor will support the continued home care, and if so, get that doctor's active support. Hopefully, the doctor will call the agency, remind them that he or she wants this care in place, that it's necessary, and that the doctor didn't discharge the care, and if possible, get the doctor to put something in writing. Try also to speak to the individual's nurse, physical therapist, and occupational therapist. Those are the professionals who are providing care in Mrs. Drew's case, about the care they've been providing, get their support for the need to continue that care. The goal is always, of course, to keep the care in place. That's why we do the work we do. The reason we pursue advocacy for Medicare coverage is so that people who need it can get the care that the doctor says is necessary. That includes the nursing, the therapists, and the home health aides. If the agency can't be convinced to continue the care, we want to try and appeal the Medicare denial. So that's why you need that written denial, which will tell you when the appeal where the appeal needs to be sent and by when. And you want to meet that deadline, or it will be made more difficult to appeal for sure. And you want to get the doctor's written support to go in with the appeal. Now, in this case, there are a number of issues presented. And these are those that I want you to know. Medicare is available to maintain or slow decline, equally to improve. That skilled care, the nurse, the therapist, is coverable by Medicare just as much if they're necessary to maintain or slow the person's decline as to improve the person's condition. It is also true that Medicare is available regardless of whether the condition is stable or declining. Certainly if the care is necessary to help the individual slow decline, and also if we think that stability will be affected by the loss of the care, and we often see that if the care is terminated or slowed down. Coverable care and services, however, must be reasonable and necessary. So it is important that we can show why those services have been ordered, both as to them being provided at home and how often they're being provided. And that's what Kathy was saying, is showing how that would be included in the plan of care. The length of time Medicare home health coverage can continue is based on meeting the basic criteria, that is that the person has a plan of care and is homebound and needing skilled care. So long as that skilled care is required, as we showed earlier, Medicare coverage is available. It's, as we saw earlier, also, it's not the responsibility of the provider, of the family, to provide the care, and it's not relevant to determining whether care is available, coverage is available for the care that is needed and that the doctor has ordered. Now, here's a new point we want to make, because Mrs. Drew is in a managed care plan, in a Medicare Advantage plan, not in traditional Medicare like Mr. Jones. The Medicare law is absolutely equally applicable to people in Medicare Advantage plans as to people in traditional Medicare. So all these citations we've given to you are equally relevant to people in Medicare Advantage plans. Regrettably, we sometimes hear that Medicare Advantage is more, shall we say, stingy with the Medicare home care benefit than traditional Medicare, and they must, under the law, provide at least as much coverage as Medicare, traditional Medicare. That includes the fact that just like people in traditional Medicare, people with ALS and other conditions that will not improve in the long term are equally able to get Medicare coverage for skilled care and the dependent home health aid services, for example, as a result, whether or not they are improving or whether that skilled care is required to maintain or slow decline of their condition. Restoration potential is not a basis for denial. And here is a quote from the federal regulation. Even if full recovery is not possible, regrettably the case for people with ALS, a patient may need skilled services to prevent further deterioration or preserve current capabilities. And if that's the case, then both the regulations, an important lawsuit known as Jimmo versus Sebelius, and the settlement from that lawsuit, and the Medicare Home Care Manual all say that improvement is not required for the service to be skilled and to be covered under the law. There must be an expectation that the patient's condition will improve, says one component of the federal regulations, to get coverage. But look at the second part here in yellow and underlined. Or the skills of a therapist must be necessary to perform a safe and effective maintenance program. So that's so important. We know that without physical speech or occupational therapy that's ordered by a physician, people like Mrs. Drew will find themselves declining and in even worse shape than they are. And so that is coverable under the law. How much and how long can care be covered? Well, as we've been saying, up to 28 to 35 hours per week combined for nursing and home health aides, and here's the citation. In practice, we know this is very difficult to find, but it is available under the law, and that physical, speech, language pathology, and occupational therapy services are available under the law as are medically necessary and reasonable, in addition to the nurse and home health aides combined that Mrs. Drew was receiving. There is no duration of time limitation. In fact, coverage is available so long as the skilled care is required. And that's so important so that people can get this care over the long term. Now, again, the fact that there's no willing, in fact, in Mrs. Drew's case, regrettably, no caregiver at all, is not, should not be an impediment to her getting Medicare coverage. She should not be told that she needs to go get a caregiver. It would be nice if she could do that. It would be lovely if she had someone at home, but that is not for the agency to decide and to therefore put a barrier up to getting Medicare coverage. Again, I want to reiterate that Mrs. Drew, like all other enrollees in Medicare Advantage, is supposed to get at least as much coverage as those in traditional Medicare. And they have the same coverage rules that apply to the coverage services we're telling you about. In fact, some Medicare Advantage plans these days are saying they may bring you in a meal, or they might help pay for a cleaning of your teeth. That's all well and good, but what we want to make sure is that they cover at least as much home health care and the other services that are required under the traditional program. Again, it's harder to work directly with home health agency to continue care sometimes if you're in a Medicare Advantage plan, because the Medicare Advantage plan may be sort of a go-between between the family and the home health agency, but they are required to provide the care that we're telling you about. So here are a few more practical issues regarding appeals and some resources. We want to help you obtain the full array of needed services. So we always are looking at that 28 to 35 hours combined of home health aides and nurse that are so important for so many folks, and maintaining services over the long term. We know that this is terribly important for people with ALS, and we don't want you to believe or be, though you may be told that it's not safe to keep you at home. That's not for the agency to decide. They can't ensure, it's not for them to declare that you need a caregiver in order for them to be in place. But we know that may happen. We want to do all we can to make the home health agency aware that they have obligations to provide other arrangements, under arrangements with other home health agencies, those skilled services, and the aides if they say they don't have them on staff. The key, frankly, is to get your not your foot in the door, the home health agency's foot in your door to provide the services that the doctor has ordered, and hopefully then have them provide under arrangements with another agency the services that they say they just don't have available. We also want you to note that there's durable medical equipment and some other supplies that may be available separately under Medicare Part B to what the home health agency is required to provide. And we want you to know that it's important to get the written denial and to get the agency to submit a bill so that you can appeal a denial to Medicare if you cannot convince the agency to provide the care and bill it to Medicare. In order to do that, and here's the kind of catch-22, you need to continue to receive the care, and the agency can require you to pay during the period that you're appealing a denial. But if you are able to do that, either through another payment source, out of pocket, through Medicaid, or in another way, They do have to submit the bill to Medicare for the services they believe that they are going to provide, but they believe Medicare will deny. They must do that if the beneficiary insists. Do contact us if you are going to appeal, and we'll do what we can to guide you through the appeal. And also, please be aware that at our website, MedicareAdvocacy.org, we have a great deal of information. So at this email address, you'll find all the material related to the Jimmo case and the settlement and the materials that the government was required to produce, including changes to their Medicare home health policy, right there through our website. We also have a home health toolkit. Here's a typo. It should say home health toolkit on our website, which has been updated to include information subsequent to the Jimmo settlement. You'll find our the Medicare revised home health booklet and our brochure, which includes information about getting care over the long term for people who won't improve. We also have a self-help packet to help you appeal. So with that, Matt, we'll go ahead and take questions and see what we can do in answering those in the time that remains. Thank you.
All right. As you could imagine, we have plenty of questions. Let's see if we can go to Angela live. It's always worth a try, right? Angela, can you hear me?
Right after school.
We can hear you.
Around 3:15, the school bus drops kids off at the neighborhood stop.
Okay. Guess we'll go with some written in questions. Angela, let me know if you get back on. We'll lower your hand for now. We had a couple questions on the recertification. Is face-to-face necessary for the 60-day recertification? If a person misses their follow-up appointment, for example, with the doctor, or if the doctor is unable to see the person, can they still get a plan of care signed, or is the beneficiary going to lose services?
Right, so there is no face-to-face required for recertification. What's important is that within that 5-day window, that at some point in the last 5 days of the original certification period, that there be a signature for a recertification. So we still want to, justify that it's medically reasonable and necessary, that the care has a plan of care. If the plan of care is going to be adjusted at all, that should take place. But the recertification that happens every 60 days, and again, typically in the last 5 days of the original certification period, that does not require an additional face-to-face encounter with the doctor.
Great, thank you. We have a question from Susan, who says, I cannot speak, but I have a question. I was discharged a year ago from my home health agency because after the long winter of being homebound, I went to see a movie with my adult son. They said, you must admit your case of ongoing care with our agency is unusual. I didn't fight their treatment. But my question is this: living in Wisconsin with the harsh winters makes going out considerably more difficult. Could I get the help I need for the winter months at least? My doctors never hesitated to give me an order for needing skilled care and a plan of care. In addition, I was told by this agency that they didn't have staff to cover any more than 6 hours a week, dressing me, and a shower on Monday, Wednesday, and Friday. And I felt I had no recourse. Thank you very much for answering the question.
Well, I'm Kathy and I are both terribly sorry for
There's so much there.
Yeah, being told all these things that made your life even more difficult. First of all, clearly, Kathy, I mean, going to the movie did not make you other than homebound,
right? And
under the law, right?
Yeah, and I'm afraid that sometimes the agencies use any excuse because
they don't want to do it.
Yeah. So, but that's absolutely wrong. And no one should ever feel that they are a prisoner in their home. And Medicare has said that themselves, that there are clearly cases where people have been able to leave the home and shouldn't that shouldn't be an issue. So that's the first thing.
Right. The first thing is you're clearly, regrettably, homebound under the law, right?
Yeah.
Second, okay, so the little tink of good news is that it sounds like your doctor is very much on board and would write an order and a plan of care to restart home care. Regrettably, in the future, if you can get home care in place, know that it's going to be much harder for them to discharge you than to insist that they start providing the care. But let's see if you can't get another agency with a new order from the doctor who you say it sounds like would make a plan of care. And certainly 6 hours a week of home health aides is de minimis, as we were telling you just now. So I would think if you do need nursing or therapy, and it sounds like maybe one of those two, at least one of those two skilled services would be beneficial to you, then get an order for that home health aide as well, perhaps for a couple of hours in the morning and in the evening each day to help with that personal care that you need. Bathing, yes, but also grooming, feeding, other personal hands-on care would be covered under the law.
Yeah, and this actually goes to Judy and I share outrage at various levels at various times about how the inequality of this and the illegality of it is just stunning. So as Judy said, if you're out in Minnesota, you're somewhere where there's not a whole lot of home health agencies.
Wisconsin.
I'm sorry, yeah. Wisconsin. You might not have a whole lot of choices of home health agencies, but check on the home health compare, see what agencies are available in your area. And yeah, the thing that home health agencies say to us is, well, getting some care is better than but getting no care at all. Well, that's, settling is really not what you should have to do, but we understand that sometimes that is true, that something is better than nothing. What we want to do here at the center is make sure that gets fixed. And so we ask all of you and anyone who is trying to get home health care, if you can't get what you need, what the doctor originally orders, because sometimes what ends up happening is the doctor order has to be diminished, as Judy said, in order to meet what the home health agency says it can provide. We want to know, because the only way we're ever going to fix this problem and make it right and make the law happen is if we know when people are not getting the care that is originally ordered for them. So please, we have the home health at MedicareAdvocacy.org. Please tell us. We want to be able to fix this, but we have to go to CMS with the correct information. I know that's not helping you. That's helping everyone in general and helping us to reach that goal of fixing this terrible problem where people are not easily getting what they should be because they're covered under Medicare. And we also, I just have to say this, we also really understand that people with ALS, it's everything they can do to get up in the morning, and people who are living with ALS and people who are helping people living with ALS. And so we don't expect you to take this battle on. We are trying to help to make sure that people get what they need, but it's challenging.
So with regard to your particular case, though, it does sound like you meet the legal qualifying criteria. Assuming you need that nurse or therapist, you are homebound, and get that home health aid and the skilled services ordered, and hopefully try again with another agency to get what you can. So, and if it turns out that while you meet the legal qualifying criteria that we've just described, that you cannot get care, do write to us or give us a call. Matt?
Thank you both. I'm going to try another live question. I'm going to Andy. Andy, are you there?
Yes, I am, Matt. Thank you.
Excellent.
I am the Mrs. Smith of this example, and I'm pretty envious. I haven't had 8 hours of uninterrupted sleep for over a year since my wife came out of ICU in May of last year. But I have a bunch of things. I asked a couple of the questions by text, but I'm wondering, my wife's progression is to the point where she's bedbound. She's more than homebound. She can get out, but only if I help her, and she has to have someone do everything for her. It's tough for me, listening to what you're saying, to establish what's reasonable and necessary to have ongoing care. When she came out of ICU last year, we had an episode for the coming out of ICU, and that lasted 60 days, and then they easily recertified her because she was in the middle of getting her speech generating device. She got a Tobii Dynavox, and but late into last year they stopped it, so she had good 4 months, May through September, of coverage, and they wouldn't renew or recertify because they said I was the one able to give her the care she needed. I could do the physical therapy and the occupational therapy because they gave me pamphlets and pictures. But I'm wondering, if I want to start it back up again, is there a minimum condition that they will say, no, we don't see any possibility of giving her care because she does leg exercises, but she's, maybe 5% of her muscle strength is left?
So there's no minimal condition. The question is whether, obviously, we want you to go through that checklist. So will the doctor order the care and write a plan of care? That sounds like yes. Is she homebound? Yes. So now, does she need a skilled service for the care to be safe and effective? Giving you brochures and pamphlets to provide physical occupational therapy or any, I don't know if she needs any help with the SGD any longer, but anyway, you said pamphlets. That's really not sufficient to ensure that this care is safe and effective. None of us who, like you, I'm not an occupational therapist or a speech therapist. There's reasons people are skilled and have these professions. They know what to do. They may be able to provide services in a way that's going to help in a way that you can't because they're a therapist. So we want to know whether the doctor will order the therapy to come back in. The PT would be sufficient to qualify you to begin coverage. The occupational therapy has to would only continue care. So we need to see whether the doctor thinks that your wife would benefit from a nurse and or a physical therapist. And quite frankly, given the condition that you tell me that she's living with, it seems hard to believe that she couldn't benefit from some nurse to look at her skin, to take her vital signs, and report any change in the care plan back to the doctor, observe and assess her condition, and with the physical therapy and occupational therapy to try and keep any pain subsiding and any slow in any way any of her deterioration.
Right.
If any of that is possible, I'm speaking quickly so we can help you as much as possible, then that would check off that part of the list. So she'd be a care plan, homebound, a skilled service, and then the home health aides. Certainly that 28 to 35 hours combined with the nurse. And that means somebody coming in the morning and the evening, hopefully get her started for the day, get her clean, fed, all the things that you're doing to start the day and getting her settled back in the evening. And that should be a relatively reasonable plan of care for a person in your wife's condition.
Right, and I would also add to that, if you've got a nurse, the nurse can come in as little as once every 60 days. And so perhaps
with a recurring order
to come in once every 60 days. And perhaps that order is to manage the overall care plan that includes directing the home health aides what to do and how to make sure what's happening every 60 days and to assess whether her condition has changed. It doesn't have to change, but the nurse would be there to come in to make that assessment. So that happens quite frequently, where there is a minimum amount of service that comes in as a skilled service. It doesn't have to be weekly, it doesn't have to be monthly. As long as it's once during that 60-day certified period, then that qualifies and it opens the door to the dependent services too.
Our agency has been good
with the physical therapy. And one of the things for both you and for others on the call is to look at slide 28 where we provide that checklist, because most of what we hear from folks living with ALS and the others who contact us is that they're qualifying for care that they're not getting coverage for. We do sometimes hear from folks who don't meet the qualifying criteria, but your wife certainly does. And on slide 28, you would find the checklist, and then you've just asked what's reasonable necessary, and I think that's for the doctor to decide, the attending doctor to your wife, but certainly something along the lines that I just suggested, I think would be so. So good luck, and let us know if that doesn't happen, please.
No, I will. I'll be contacting you. I've gone through the checklist, and I submitted a question at the last seminar about how the agency denied it. They said they have 2 years of backlog in fighting Medicare over this. Even with someone who does have is homebound and meets the checklist, they just aren't getting paid, and they would put that cost on me, and I don't know that I can afford. Well, I'd hate to have to afford 2 years of all these services.
Okay, so that's another thing. Don't assume it would be 2 years. Let's take a couple of these. If you can manage to get the care in place for a period of time, then write us a note there, and we can't take all these cases on because we don't have the resources, but we can take a few that clearly qualify and do the best we can to help.
And hopefully we answered your question, because we did send out answers to the first 2 webinars or on Friday, I believe.
Okay, I didn't see that in my inbox. I didn't see those yet. Okay, I'll look for them. Thank you.
Okay, thank you.
Thank you. Anybody that, like Andy, maybe didn't see the answers to the prior webinar questions who did attend, please email me. You can email mshepard@medicareadvocacy.org, and I'll make sure to get you a copy of those. We have another live question on the line. Let's give it a shot. Pat, are you there?
Yes, I am.
All right.
My father has been diagnosed with early Alzheimer's, and he also has major mobility issues. He's basically confined to the bed. He can't transfer from the bed to the wheelchair, so he's pretty much wheelchair bound in his home. We're trying to get him extra nurses' aid care in the home under Medicare. So how would this work?
Well, again, as we just described with Andy, it would be kind of the same. Go to that basic checklist.
I'm sorry, I don't know where the basic checklist is. This is my first one.
Slide 28.
Oh, slide 28. Okay, thank you.
It would help, I think. And so you need to get to the doctor, his doctor. You need the doctor to always for any service, has to order it and write a plan of care, what he thinks your father would need. The underlying diagnosis should be irrelevant to Medicare coverage. They should never deny based on a particular diagnosis, or grant for that matter. So if your father, it sounds like, as we just said to Andy, his wife, your father is homebound, so that criteria is met.
He's not only homebound, he's bedbound. He can't even get up on it.
Yes, I understand that. So that criteria is met. And then if he's bedbound, the question is, and he has Parkinson's, does he need?
He doesn't have Parkinson's. He's got Alzheimer's.
Alzheimer's. I'm sorry. Does he need a nurse or physical or speech therapist, language pathologist? Because one of those skilled services is necessary in order to begin Medicare coverage.
I'm sorry. Which skilled services? Could he have a nurse come out one time a month?
Yes, as we just described, intermittent skilled nursing can be as infrequently as once every 60 days, but on a recurring basis.
Okay.
Or physical or speech language pathologies.
My father can't walk on his own. Physical therapy isn't going to help him. I'm sorry.
Well, anyway, then the nursing, and then that would begin services, and then the home health aides could be covered.
For up to 35 hours a week?
Combined with the nurse. If the
nurse comes out once every 60 days, he could probably get close to 35 hours a week with home health care aides.
Theoretically, under the law, that's available. 28 hours, and then the 35 hours has to be particularly documented as to why those extra 7 hours. But
my father can't get out of bed himself, and he has no full-time caregiver.
certainly a lot more than what he's getting now. So I hope that's helpful, and look at that
A
slide.
lot more than what he's getting now. He has a nurse's aide coming out for 2 hours a week.
Yes, well, that's too little. And if you need the nurse, he needs the nurse, then Medicare could cover far more.
Okay, okay. This has been a very informative, even though it's regarding ALS, it's been very informative to me because I was not aware of all this. In this Jimmy case, this Isabella's case is called this, has helped folks with these issues. Is that it?
Yes, absolutely. In fact, the Alzheimer's Association was one of the plaintiffs in the case. And again, yes, so I hope that's helpful, and go to our website and you'll find some more information.
Now, what is your website? Medicaladvocacy.org?
See it right here at the bottom of each slide, Medicare Advocacy.
Okay. Yeah, that's very helpful because honestly, I've gone through the Philadelphia Aging Society for the options program to get them extra nurses' aid care in the home for 8 hours a week is what they told me the max was on the weekend, 4 hours and 4 hours. And my father really needs even extra hours during the week, in my humble opinion, honestly. So this has been very informative to me. I did not realize that this Medicare may be able to help with this.
Well, I hope so. Thank you.
All right, I appreciate that. This is a great webinar. I appreciate you're doing this.
Thank you.
Thank you very much. We are a little bit over time. We've got quite a few diehards still on the line. We have another hand raised. Shall we try to go for that one?
Yes, and again, I hope that each question and the answers, as you know, I hope everyone knows, relate. The details are particular to each case, and that's important. But the concepts are true for all dealing with these circumstances. Yes. So the next question.
All right. Let's try Patrick. I cannot unmute Patrick. It looks like he might be.
Let's take another.
Oh, nope, there he goes. Are you there, Patrick?
Yes, I am. Can you hear me?
Yes, thank you.
Thank you, Matt, for taking my questions. I have a couple of questions. I'll try to keep it brief. Hopefully the answers are brief. I live in Louisiana. I'm covered under Blue Cross Blue Shield. I had previously applied for the community choice waiver and was approved. However, I declined it. I did not sign the form. Number one, nobody could really give me any answers to asset recovery. Is there any information on your website concerning that?
So, no, but since you're in Louisiana, I would point you to my dear friend Liz at Team Gleason, because Liz is learning everything there is to know about Louisiana and asset recovery. So in every state has a different application of their rules around how they recover assets. So that would be my first choice, would be to call Liz and ask Liz. And if Liz is on the phone,
I will gladly email them. Next question. Should I decide to go to the community choice waiver and accept it, would that be my primary insurance? Can I keep Blue Cross Blue Shield, or how does that work?
so do you have Blue Cross Blue Shield through Medicare? I just want to understand.
Like as a Medicare Advantage plan?
Negative, through my retirement.
Okay. And are you on Medicare at all?
No, I am not.
Okay. Okay. So yeah, it would be hard for us to advise you. You'll have to check with Blue Cross Blue Shield. I will say that one thing we do know is that Medicaid is typically the payer of last resort, what they call the payer of last resort. So my guess would be that the community choice waiver is tied to Medicaid. And in that instance, Blue Cross Blue Shield would be the primary insurance, and then the community choice waiver would be secondary.
Okie doke. Well, I appreciate that. And I'd just like to say thank you all for y'all's time and effort over these last 3 sessions. Look forward to more town hall meetings and so forth.
Thank you.
Terrific. Thank you, Patrick.
All best.
Actually, that seems like a pretty good transition. We are a little bit over time. I know we've got some questions still that we didn't get to today. We had a couple people who wrote questions in who are no longer on. So I'll try to gather all those questions and we'll get some answers out to you folks.
Or also we'll attend to many of them at the town hall session in June. So.
Right. Always nice to have some seeded to start our town hall discussion.
Yes.
I want to thank everybody for attending today's webinar, and especially the folks who attended the entire series, the diehards. Thank you to Judy and Kathy for another incredibly full presentation. And please do join us June 13th at 3 p.m. for the first of our 3 town halls where your questions and your stories will be the spotlight. You can sign up right on our webinar page, right below the Team Gleason webinars. So go there today and do it. Thank you all again, and I will conclude our webinar at this time.